So I'm sure that you're all aware of the burden that muscle and joint conditions place on both the lives of our patients and also the NHS in the requirement for provision of care. Muscle and joint conditions account for 30 million workdays lost each year, with back pain being the second most common reason for requesting a fit note. They account for up to a third of all GP appointments, and that's over 100 million each year. And the MSK system is also the most costly body system to the NHS. So I know that you know the importance of our role as GPs in managing these conditions and playing a part in the recovery of patients and improving the quality of their lives. However, I wanted to dial up the focus on the promotion of self-management advice and in particular the completion of self-exercises. In the current climate created by the COVID-19 pandemic, with total telephone triage, video and online consultations, many of us have been asked to change the way that we interact with patients. And to add to this, we currently have very limited access to the conventional treatment pathways of physiotherapy and secondary care. So it's really important for us to look at how we can adapt our treatment processes to this changed landscape and look at what resources are now available to assist us doing this. So I'm Chris Castle, I'm a GP and I have a particular interest in the MSK system, and that comes from having worked as a physiotherapist in both the NHS and in the sports setting. I am an NHS clinical entrepreneur and also part of the RCGP Innovation Mentorship Programme. So when I qualified as a physio almost 20 years ago, the course was full of manual techniques and fantastical machinery. However, it didn't take me long after entering clinical practice to realise that to effect lasting recovery for the patients required an exercise programme, and more importantly for the patient to buy into completing it regularly. So thankfully there is now a substantial body of evidence that supports this approach, and the storerooms of many physiotherapy departments have replaced their machinery with TheraBands, wobble boards and gym balls. So if I fast forward a number of years into a new career, I can see that as GPs we're in a position to effect a great deal of benefit in the recovery of muscle and joint conditions and the patient's quality of life during this process. So, however, the pressure of time has meant that we're unable to spend the time with patients to individually teach them these exercises. And as a physio, I was often frustrated that during the 6 to 8 week wait, many patients had not started any self-care at all, often due to their fear of doing more harm. So, having worked on both sides of this process, I've been able to understand the challenges and to suggest some ways of improving things for both ourselves and our patients. Firstly, surveys have suggested that generally confidence amongst GPs for making a specific MSK diagnosis is low. And I believe that this has a significant impact on our management strategies. More importantly, knowing how to promote self-management. Now, I think that this is based on the assumption that the diagnosis is key to guiding successful treatment, and I want to bust this as a myth. So if we look at a patient presenting with perhaps shoulder pain, which is the second most common MSK complaint after back pain, how could we differentiate between a subacromial impingement, a subacromial bursitis, a rotator cuff strain or a supraspinatus tendonitis? So as a physio, we are taught lots of special tests that as GPs we definitely don't have the time to complete. But even if we did, whilst the sensitivity is high, the specificity is low. And that tells me that if it hurts to move, the tests are going to be positive. And that's not necessarily of great benefit. But even then, the specific test doesn't really matter. And I'll explain why. So once we have excluded red flag pathology, and as GPs we're very good at doing that, we should have high confidence in our ability. But once we've done that, we're left with the vast majority of conditions that we see, which is either caused by either repetitive movement or poor biomechanical movement. Now, trauma from repetitive movement is easy to identify from the history. And what I mean by poor biomechanical movement is that the patient has learnt to move, sit or stand in a way that stresses particular muscles or joint structures until it triggers a pain response. Our understanding of why exercise therapy works is that it changes the way that people move by reprogramming or movement reprogramming of muscle movement patterning. And as an infant, we build up these patterns of movement that enable us to walk, run efficiently and effectively. Over time, these programs become corrupted by minor niggles, deconditioning or lifestyle or occupational activities. And these gremlins in our movement patterns predispose us to the types of muscle and joint conditions that account for these vast majority of MSK conditions that we see in general practice. So we can protect against these with conditioning advice such as yoga, Pilates or strengthening, and also lifestyle advice to avoid unhealthy postures and habits. But once patients have developed a complaint, the key message to them should be you need to move, and you need to move in a different way. So it's helpful to provide them with some examples of how to move differently or how to learn to move differently. And that's where effective signposting to self-management comes in. So my second point is about how we do that. So I firmly believe that as GPs we are expert signposters. However, I do think that we have a tendency to let our low confidence in making a specific MSK diagnosis influence our effectiveness at signposting to self-management resources. So hopefully we feel confident in our ability to exclude red flag pathology and now reassured that making a specific diagnosis is less important. 85% of patients that attend their GP with a muscle and joint condition require only advice and exercise information. Selecting which patients are going to be receptive to it is a different matter. Of course, a small number we will send for further investigation with sinister pathology screening, but how we decide which patients are appropriate and receptive to self-management advice is another issue. So I think understanding why patients present to the GP is helpful in understanding which patients are going to be receptive. And I think that patients can be split, broadly speaking, into two categories. So the first category, which is those seeking reassurance and guidance, which is the majority. And the second category, which is those that are fearful of significant pathology, sometimes underpinned by psychosocial factors. So I believe that GPs are very good at distinguishing between patients and which one fits into which group. However, with the rise in virtual and online consultations and the rise in the number of healthcare professionals in our teams, it's helpful to know that there are some tools that can help us do this. So in particular, Keele University's Start Back questionnaire, more recently their Start MSK questionnaire that covers the 5 most common joint presentations. These are simple questionnaires pertaining 10 questions, and with the permission of the Keele University team, can easily be sent to the patient and attached as a text message link or emailed to the patient for completion prior to attendance. So in this way, we could effectively reach out to those patients that just want directing to the correct self-management advice so that they can start their rehab journey sooner. It's also a useful documentation of the treatment stratification process. So despite this, there is a role for the GP to provide specific reassurance and encouragement for self-management. There is evidence that use of exercise is in the majority of muscle and joint conditions. So as mentioned before, this is thought to be due to the changing patterns of movement. Now clearly, a patient could therefore be given a number of different exercises to achieve this ends, so it's important to guide the patient in a way that the patient is receptive to. This might be in the form of a paper exercise sheet, as per those made available by the Chartered Society of Physiotherapy, or the Charity versus Arthritis. Or it could be via a website, as per the NHS Choices website, or even a smartphone app. So the benefit of the app is that it enhances the engagement from the patients, and we know that that improves their rehab compliance. So my shameless plug is that I am the lead of a muscle and joint self-management app called GPEP, GP Exercise Prescriptions. It is available in both the Apple and Android app stores for download, and it's a patient-facing app that is currently free to access using the code COVID-19, COVID in capital letters. And during the patient trial with the app, there was the benefit of it reducing the demand for GP appointments, and that was coupled with good patient feedback. So it's also been top rated by the Chartered Society of Physiotherapy and also the Independent App Review Organisation, ORCA. So there are others available, and I would encourage you to base your signposting decision on a recognised app review organisation like ORCA. And that should offer some reassurance in which ones to signpost to. So if you are interested in finding out more about anything that I've mentioned, then please make contact with me, and I'll be very happy to answer your concerns and queries. So thank you.